the Pre-Med Year, session number 338. Hello, and welcome to the Pre-Med Years, where we believe that collaboration, not competition, is key to your success. I'm your host, Dr. Ryan Gray, and in this podcast, we share with you stories, encouragement, and information that you need to know to help guide you on your path to becoming a physician. Welcome to the Pre-Med Years. Thank you for taking the time to join us today. Today, I have a very interesting guest, a very interesting topic that many of you are going to be like, why am I going to listen to this? But trust me, the more that you can learn about this topic, the better physician that you'll be, the better medical student that you'll be, and the better person you'll be, because everything in your life, you will start to learn how to make it better. Now, sometimes I go a little bit overboard with this thinking because I love continual process improvement. And Allison, my wife, gets mad at me sometimes. She's like, why do we have to improve this process? I'm like, because we could save like 5 seconds doing this every single day. And that adds up. But I'm having a great guest with the director of the Healthcare Systems Engineering program at Lehigh University, Ana Julia Alexandrescu. So let's go ahead and jump right into the conversation all about process improvement. Ana, welcome to the Pre-Med Years. Thanks for joining me.
Thank you for having me, Ryan.
I'm excited to talk to you because I can geek out about everything that you get to geek out on every day. And it kind of has to do with healthcare, but kind of doesn't. But in the big picture, I'm excited to have this conversation because I think it's something that every student going into medicine needs to be thinking about and needs to be aware of. And now with that cryptic opening, you have or run or director of a master's program at Lehigh University, helping physicians and pre-meds and others learn healthcare systems engineering, basically. Yep. Explain what that is.
It's a good question. So I guess probably the best way to put it is thinking about how to plan, design, manage, and run systems of healthcare delivery. Now, that's a mouthful. So what does that really mean? Goes down to the fact that healthcare, as we know it, as we see it, as it's happening in 21st century, it's a very complex system. Lots of moving parts, lots of people, lots of processes, lots of subsystems and pieces that have to work together in order to come up to a coherent picture, which largely we don't have. So systems engineering is how you think about such a system and how you put together processes and systems of care delivery and how you make all those parts work together in unison so that you end up with good patient experiences, good experiences for care providers, efficient, effective, safe care, resilient systems that recover quickly when there are disruptions of various kinds, and so on. So it has a myriad of applications in any kind of or any part of the healthcare system that you can think of.
So how did you get into this? What's your background?
So my background is in industrial and systems engineering with an emphasis on operations research. And I sort of got into healthcare by accident through a string of projects that I did as a student. I learned more and more about various aspects of healthcare and various ways in which healthcare doesn't quite work the way it should work or could work. And so once I graduated, I worked for a boutique consulting firm, working a lot in business process reengineering. And now I am in my current position, work with students and industry partners on a lot of healthcare delivery system-related problems of all sorts of nature. So I come at it from the engineering perspective. I don't have a clinical background myself.
Yeah. So a lot of students listening to this will think, well, how does this pertain to medicine? Why is this important? as a physician, I'm going to show up to my clinic. I'm going to see patients, and I'm going to prescribe them medication. They're going to go on their way, or I'm going to show up to the OR. I'm going to do the surgery, and they're going to go on their way. Why is this important to me?
It's a really good question. So I would say that the way to think about healthcare systems engineering as a pre-med student or future medical professional is that we look at everything that happens outside of the room or outside of the pure interaction with the patient. So, for example, if you're an emergency medicine physician, you work in a very chaotic environment where people keep coming, they wait for a very long time. Sometimes they leave the emergency department without being seen. Sometimes they wait even after being seen before they get transferred to an inpatient bed. As an ED physician, all of this affects you, affects the environment in which you work, affects how care is delivered to the patients you care about, affects everything about how that emergency department operates. If you have a healthcare systems engineering perspective on top of your medicine perspective, you can start looking at ways to do triage differently, ways to organize and manage the operations of that emergency department such that it functions better, such that people spend less time waiting, such that physicians are using more time with their patients and on clinical duties rather than on other things that keep them away from practice. Similarly, we've had a number of surgeons go through the HSC program, and the operating room is another environment that has a lot of moving parts and a lot of complex operations involved with it. Some of the questions that you might want to figure out is, do you start a colon cancer surgery with a robot, or do you start it open? And what if you can predict the risk of having to switch from robot to open because of likelihood of complications based on information available before the surgery? How do you sequence your surgeries? Do you put the longest surgery first or the shortest surgery first? How do you manage your day such that you, for example, as a surgeon, minimize disruptions, spend less time idle and waiting for things to happen so that you can get on with your day, and then are all in all just more effective and more efficient, and therefore provide overall better care in a more pleasant and well-functioning environment. So we look and we think about all of these aspects. Now, there are certain things that, for example, as an engineer, I can look at your schedule as a surgeon, and I can definitely give you recommendations on how to improve that schedule or make it less likely to run long, less likely for certain surgeries to be canceled, better at predicting how long each surgery will take. All of that is in my power as an engineer. But there are decisions or aspects that I cannot really control, or I do not see, I do not have access to because of lack of clinical information. So essentially, I can give you the recipe or the reasoning or the logic why you might want to make certain decisions one way or another, but I lack the clinical context to push that beyond a certain level. But you, as a clinician with this sort of mindset, don't have that barrier. So you can go a lot further and apply some of these concepts into designing new treatment protocols, new ways of approaching diagnosis, new ways of practice, better care delivery models, and so on.
Can you give an example of a problem? I know you guys look at through your program, you look at complex issues and try to solve them in as a group. What is a big problem that has been solved recently, or at least improved recently, that you can give an example to us about?
Sure. So we worked with a resident in colorectal surgery and another physician from a colorectal surgeon to look at predicting the likelihood of, so in colorectal surgery, there are certain surgeries that are inaccessible. So with a robotic assisted surgery, you actually get better visibility in certain cases and perhaps better access. On the other hand, robotic surgeries can take a much longer time. They're much less invasive for the patient, so the patients recover quicker. But if there are complications, essentially you have to take the robot and the robotic team out and then scrub up and then bring in another team that is different from the robotic surgery team to begin with. So the questions here were twofold. One, are the outcomes for patients worse when we start off with a robotic surgery and then we switch to open surgery partway through because of something that happened as a complication during surgery? And the second was, could we, based on information available prior to the surgery, predict the likelihood of that switch happening? And given the risk tolerance and the surgeon's evaluations of that risk, make an informed decision whether this particular surgery is better to be done via the robot or better to actually switch to open surgery to begin with. And so this used NISQIP data from over 600,000 surgeries performed in the United States, limited to obviously the ones that we're looking at. And the starting point was that to build a predictive model, first to compare statistically the population that started with the robot and switched to open versus had open, controlling for various differences. And the results showed that, yes, indeed, the outcomes are worse for patients that start with robot and switch to open versus patients that with comparable patient background actually completed the surgery via open. And second, assuming given the information that we have available prior to the surgery, can we build a predictive model that can relatively accurately predict the risk of that switch having to happen? And based on that, make an informed decision whether to go on with the robot or not. And then the predictive model also achieved a relatively good performance. Obviously, this could be further improved, but it's a starting point to at least start to build that kind of reasoning in the decision-making process prior to colorectal surgery. So that's one example.
Yeah. How is that different? A student listening to this will be like, well, that's similar to research that I do looking at patient outcomes for one type of procedure versus another. How is this healthcare systems engineering mindset different than just doing research and looking at patient outcomes?
So I guess the general idea is that this just looking at the patient outcome difference is one aspect of it, but there are operational implications to making that decision, even if there may not be patient outcomes. So for example, let's say that there isn't really, it wasn't the case in this case, but let's assume that truly there were no differences between patients who started with robot and switched to open versus patient that started open. So from a patient recovery and experience perspective, it didn't make a difference. That doesn't mean there isn't a difference at all from a system perspective. From how long should you be booking your operating room? What disruption that causes to other surgeries scheduled that day, to the patient recovery planning. Like I said, robotic would be much less invasive versus open would be like the patient recovery is a lot longer. What implication does that have, not just on the patient level, but also on all the operations in the hospital around that particular surgery, both in the OR room as well as in the recovery, in the PACU, and then afterwards in discharge. I can also give you other examples that are happening in more operationally complex environments. For example, looking at we had a project, both students are now in medical school, they're both pursuing surgical careers, but they worked with trauma surgeon, the trauma surgery team, particularly two trauma surgeons at one of the hospitals in the region looking at the process for ICU step down for neurotrauma patients. And the challenges there were really around communication, coordination, and logistics for basically making sure that patients that have been cleared for step down, so from moving from the intensive care unit to a less intensive care environment, to actually complete that move. And the failures in the system that are not really traceable to any one particular person or area, but rather just the pieces not fitting together properly, would lead to people being in the ICU much longer than they were supposed to originally, which takes up space in the ICU, blocking other people, other patients that need the ICU in the OR or in the ED or elsewhere in the hospital where they remain stuck because they can't get access to the care they need. And it's also bad for the patients in the ICU because the ICU is a very restrictive environment. So a number of different services that a patient might need are not actually available or possible in the ICU. So it overall results in less optimal patient care for both the patients that are stuck in the ICU longer than necessary and others who can get access to that resource. And it's not in the current healthcare environment. As an engineer, I can look at this process and I can say, this is bad, doesn't work as it should be fixed. However, the number of decisions that are being made are staggeringly many, and they are deeply clinical. So I, as a pure engineer, don't necessarily have the authority or the basis to make specific recommendation on how to fix it. So I can have many ideas. I can analyze many different ways in which this could be made better. But it takes a clinical mind and a clinical understanding of the processes in order to be able to improve this particular situation. So does that make sense?
Yeah, no, it definitely does. And it makes sense for me because I love this type of stuff, this type of constant process improvement and this sort of thinking. For the student who may be being exposed to this for the first time right now, how can we introduce to them a way to start thinking about this sort of process improvement in their everyday life?
Well, I guess you hit the nail on the head because I think both you and I apply a lot of these principles quite often. So a lot of these principles have been applied in other industries and in other processes and systems, and you see their results in a lot of everyday life. So starting from evidence you see and then moving on to things that you can do. So from things that you see, a lot of us that have Prime membership get deliveries in 2 days, pretty much anywhere in the United States for a staggering number of things. That is only possible through a very robust analytical platform and a way of thinking and predicting demand and trying to anticipate what will be required and being relentless in improving operations for delivery. I think there's been an announcement actually that Amazon is experimenting with Prime delivery for 1 day. Mm-hmm. So there are many different the way for example, if you get a credit card statement and you look at it, you usually can read it. It's pretty easy to read. If you get a healthcare bill, tough luck. Many people can't read them, and they're much more complicated, right? So there have been efforts in many other industries to become much more customer focused, and a good example that people use is comparing healthcare with airlines. And if you're trying to fly from, let's say, New York to Seattle, you're probably going to have to connect, but you don't have to buy your luggage pass separately and you don't have to manage how your luggage makes it from one connection to another, and you don't have to buy yourself like the landing spot on the airport or anything like that. Whereas in healthcare, that doesn't quite work as streamlined, and people oftentimes have to piece together across a fragmented system what they need. So there have been, everywhere you look around you, the fact that when you buy an iPhone, you're guaranteed for it to be the same as the next iPhone, that is systems engineering at work. The fact that every iPhone, as much as people might disagree with that, but the fact that every iPhone is in some way better or superior to the previous iPhone is the same idea. This relentless pursuit of better, improved excellence, and so on. Now, the kinds of things that you can do in your life. There are a number of process improvement principles that apply very simply. For example, there is a methodology called 5S, which talks about how you manage. It essentially started with how you manage your tools and your work environment, but it can apply to how you organize your desk or your closet or your subjects or your folders on your computer. And the simple way to think about it is having a place for everything and putting everything in its place. Coming up with the system that keeps you organized significantly reduces the amount of time you have to spend looking for things. And it makes it very easy to figure out when you're missing something. In surgical cases, for example, this would translate into having a tray that has all the necessary instruments in their proper place. So when one of them is missing, you can notice immediately that it's missing. And you also can shorten the amount of time it takes you to retrieve the correct instrument because it's always in the same place, always in the same location. So you don't have to search for it, which again doesn't sound like a big deal, but when you're doing many different surgeries and you have to search for an instrument every single time across a set of like 50, it can add up. Another quick principle refers to root cause analysis. So oftentimes, this also has a parallel in healthcare, where we always say you should treat the cause rather than the symptom. So root cause analysis has many different, I guess, flavors or variations, but essentially it's a systematic approach to trying to understand why a certain symptom or effect has been observed. One simple way is to adopt the toddler methodology, which is to keep asking why. They recommend 5 times. Sometimes you might need to ask more than 5 whys. But essentially, you can do that and then get to the bottom of things. So why did the patient wait for a very long time in the emergency department? Well, because there was no room available. So if you stop there, you might get to the erroneous conclusion or potentially erroneous conclusion that emergency department needs more rooms. If you continue to ask why, you find out that, well, the rooms were occupied by patients who are waiting to be transferred in the beds upstairs in the inpatient units. Okay, so if you stop there, you might reach the erroneous conclusion that the hospital needs more beds. If you keep asking why, you figure out that the beds were actually occupied by patients who were waiting to be discharged and hadn't left yet. So we couldn't clear their room, so we couldn't get a patient in, so we couldn't get a person from the waiting room into the emergency department. And again, you might stop there and then you say, well, okay, then we need more people to do discharges. But then if you keep asking why, you might, reach the conclusion that the person is waiting because their discharge papers were completed by the morning nurse, and then she left shift, and now the afternoon nurse is in, and she doesn't know exactly who needs to be discharged and how, and the information transfer hasn't happened, and that's why the person is still stuck there. But until you get to that deep level of why, you would be making a lot of wrong decisions about building capacity in the emergency room, adding more beds, hiring more nurses. without actually realizing what the true problem is that caused the bottleneck and created the problem all the way down. So this works in life as well. Whenever you get confronted or notice a particular, I guess, symptom or a particular effect, and trying to understand what the cause of it is.
Yeah, I think that's always the thing that I'm on the lookout for. Having gone through the majority of my understanding of this came from the Air Force. They do a lot of this sort of process improvement type teaching, and I just grabbed onto it, and I really enjoyed it and dug into the Lean and Six Sigma stuff and the Toyota method and all this other fun stuff. And so in my world, almost everything that I do, I'm continually asking myself, is this the best way to do this? If not, how can I improvement? What am I looking for? And so I think from a process improvement standpoint, that's, I think, the biggest thing that I want people to take away from our episode today is just to continually challenge what you're doing every day. Is it the best use of time? How much waste? And if you dig into this stuff, you'll learn that there are different types of waste. How much waste is there in what you're doing? And is there a way to potentially improve it? So I think that's what I hope students take away today is to think through those things, right? If I give just a silly example of when you're emptying the dishwasher, right? You don't put your silverware in a drawer in another room. You put it in a drawer in your kitchen because that makes the most sense. So you don't have to walk around in all these different parts of your house. And so just continually thinking about just using the kitchen example, like where do I have my toaster? What drawer do I have my silverware in? Am I constantly going across the kitchen to get stuff out of the silverware drawer when maybe I can move it to a different place and remove that waste? So that's the kind of stuff that I like to think about.
Yeah, no, I completely agree. And I think actually kitchens are a perfect example of studying processes, like good, I guess, principles of good processes and good system design. So they're technically, what do you do when you take something out of the fridge, right? You need to generally put it in the counter, or maybe you need to wash it, or maybe you need to chop it. So you really don't want your sink and your fridge to be very far apart, like in opposite corners of the room, because that will make you, like if you need to take out, I don't know, tomatoes, peppers, and lettuce, you already made 3 round trips across your kitchen just to take out and wash and deal with 3 items. Similarly, when you wash things or drain things, you usually want to go from the sink to the stovetop, and you don't want those to be across the room either. So I've been paying a lot of attention to this because we are coincidentally looking to buy a house, and so you would be surprised how many poorly designed kitchens there are out there.
Definitely fashion over function.
Yes, and it pains me. Yeah.
So you have an awesome master's program to teach these principles and this education to students and to physicians, and obviously we're talking to the majority of pre-med students right now. What can your program offer students so that they can potentially have a better understanding of all of this before they even go into medicine for real?
So I think that's a great question, and I would say probably I guess I want to talk about 3 things. Number 1 is that residency programs have started requiring process improvement projects as part of the residency. So there is an increased, I guess, understanding and perspective from the clinical community of the need to train healthcare professionals, in this particular case, med students or residents, in how to think and how to approach improving processes and systems. Because one thing, as much as you and I are talking right now about how we like to think about these things, one of the hardest things to change is to change something that you've been doing in one particular way forever and ever. So getting that practice and that habit of thinking critically and looking critically at how you do things and thinking about how you do them better is a really important skill to have. And it's reflected in the change on the residency requirements. Second is that more recently, the AMA has launched new guidelines for the kinds of things that you should be studying in medical school. And then there's a push for this idea of healthcare delivery system science. And again, the concept being that we need to think about medicine and the practice of medicine as this complex team sport that has a lot of different moving parts, and that automatically requires a set of tools and a set of thinking models and patterns that you don't really get from a pure clinical or science curriculum. And so what my students get is that kind of a perspective and practice doing that sort of thinking and thinking about medicine and about healthcare in that way before they even hit the medical school. So we run them through not only process improvement, but once you figure out how to think about processes and systems, you can actually become relatively analytical with how basically how you can think about which improvements to apply and how and where. And so we have courses dedicated to those. We have courses dedicated to understanding finance and how the money plays a role in how healthcare is delivered, both at a hospital level and also from a physician's perspective. We have courses in information systems, so understanding how you can utilize information systems to drive decision making. If I had a penny for every physician I learned from, or every time someone said that physicians hate EHR systems, I would be a really rich person right now. So that course aims to some extent demystify EHR systems, but also develop a concept of the use of information as driving or enabling better decision making. So we try to give students, and in this particular case, pre-med students, a well-rounded perspective on what it is to be a healthcare professional and what it is to think about systems of healthcare delivery with using all these tools and all these different perspectives. I think this, I've seen and I've known from students who have applied and are now in medical school, this gives them an edge in their application process. It also gives them really a different perspective. So everything they learn in medical school overlays on a different concept of medicine and care delivery than they would have had they not really looked at it from a systems perspective.
For the student who wants to dig into this sort of information now, do you have a go-to book that you recommend everyone read to get a kind of primer on this?
I guess not a book. There are many resources available out there. So there are books by Clayton Christensen, Innovator's Prescription being one of them. I was actually having a very interesting conversation with one of my students earlier about that. There are books that have been written about the Toyota production system, looking at Virginia Mason or ThedaCare or Intermountain Healthcare is like examples of organizations that have adopted this sort of mindset of continuously improving and striving for better. Mayo Clinic is an excellent example. Mayo Clinic has had a systems engineering group since its inception for about 100 years. There are a lot of different tools through the Institute for Healthcare Improvement, things that preach lean in hospitals. So there are many different books and resources out there.
Yeah, I think the book that I always turn to first for people who are interested in this is a book called The Goal. By
that's also
Goldratt.
good.
Because it's an interesting book. It's an older book, but it's written through storytelling, through a story. But it does a really good job of portraying the information that you need to know in kind of a fun way. So that's where I think I personally would recommend students to start with. But they can also go check out the master's program at Lehigh. Tell them how they can get some information about that.
So we have a website, hse.lehigh.edu. That would be a good place to start. You can also figure out what some of our alumni have been doing, those that have not gone into medicine, and also read some articles on different applications of systems engineering in different arenas. And there are resources that you can link to from our website. Probably a good resource, though it's a bit heavy. In 2014, there was a PCAS, so President's Council of Advisors on Science and Technology, published a report on the need for systems engineering and system thinking in healthcare, and it called really for bringing that education into the workforce among clinicians, administrators, and public health officials. So it wasn't restricted just to clinical professionals, but rather touched all different areas of healthcare. And that comes, if you just Google 2014 PCAS report on healthcare systems engineering, that provides very good examples of specific applications of systems engineering in healthcare in many different settings. And it gives a very compelling argument as to why this kind of thinking is needed in healthcare, and why it should be built. And that comes on the heels of a number of other reports from Agency for Healthcare Research and Quality, an NSF and Institute of Medicine collaboration from the early 2000s, and a number of other reports and publications in this vein. So I recommend the report, even though it's a bit long and a bit big, but it actually makes a pretty clear argument as to how to think about healthcare and why, when you think about it that way, you need systems thinking in it.
All right, there you have it. Again, that was Anna from Lehigh University, Healthcare Systems Engineering. It is a master's program. If you are thinking about taking a gap year and you want to learn more about healthcare systems engineering, I would highly recommend going and checking them out at hse.lehigh.edu. Now, this master's program wouldn't be a good master's program if you are looking at improving your GPA and using this as a post-bac program. This is a master's program if you are really interested in process improvement and healthcare systems engineering, and you want this knowledge base for your future practice, or if you're thinking about going into administration, wherever you are thinking about going and you think this may be useful, this is definitely something that I would check out. As always, you don't need a master's program to start learning this information. Anna gave a couple recommendations on what to look into. I gave the recommendation of the book called The Goal. We'll have links to all of that in the show notes. I hope you have a great week. We'll be back here next week for some more pre-med years. See you later.